using the
Professor, I have a quick question.
Yes.
So in the math,
Recording. Again, the last class takes their exam on Friday afternoon. So the exam analysis takes place at 5 p.m. Eastern Standard Time, just like it did before. And then so shortly after, you will receive that announcement that the exam analysis has taken place and your grades will be posted. In addition to that, we'll let you look at your grades with just the which are just your exam scores and your quiz scores. So what I will probably do is wait until Saturday to turn homework grades on. But I want to recall you go back to week one and your book, your your campus policy and procedure about those key graded assignments. Because yes, your grades do change when we turn the homework grades on and off. But remember, both of them must be at a minimum of 78% without rounding in order for both of them to even count. So just keep that in mind as we move forward. We do have one exam left. You do have your HESI unit exam 3, and then you have, I think, about 2 quizzes left. So just think about, spending your time with the concepts and gaining that understanding. Because as you can see, the questions they're like next gen style. There are some that ask you a definition, but for the most part, you have to be able to pull that information out of a scenario and apply what you know about the concept in order to answer the question. So, if we don't understand what the concept is, then it's going to be difficult to be able to, sift through and pull out an answer that is correct. All right, so let's look at our, let's see, our little guide here, and we are in week 6. We're halfway, pretty much over halfway. Don't forget, week 12, we meet. This is a Wednesday class. So week 12, they usually campuses close like at noon. So usually we send an announcement for you to meet at an alternative time. That's usually not an issue, just to let you know, give you heads up on that because we are getting close to week 12. And it's just to meet to complete your that survey that comes from education affiliates. And then we meet and we kind of look at our scores overall, comparing them to nationals. Week 11 is going to look different for you because that's when all the HESIs, you will have all the HESIs. So if you're taking 1 class, 2 classes, or 3, all HESIs are in that week. So usually by the end of week 9, for sure week 10, you will be getting that information from your campuses. It is campus specific. While this is not a late class, sometimes the HESIs are, especially I know if you have a class later than this on another day, HESIs are generally not given really late, but nevertheless, you will receive that information from your campus dean. That week, the timing may look a little bit different. Because like I say, sometimes the HESIs are not given like doing the regular class times. The other thing is, if you take this class on Wednesday, this class, remember, it's offered all week. The HESI for this exam on your campus might actually be on Friday. So just be kind of, penciling that in on your week 11 because it's going to more than likely look a little bit different from what the rest of the term look like. So be thinking about family, your work, and everything for week 11. But for sure, no later than week 10, you should have specific information from your campuses about where you should be and the times you should be for all of your HESIs. And then week 10, that is going to be where we present our group project. And then we just go over concepts thereafter, just going back because there's no new information after week 8. So week 10, you have your project. So make sure that you're communicating regularly. If you need to revise something, change it up. It's okay. Go ahead and do that because most of the time your plans that you have initially, they do change. And so make sure that you're communicating regularly and ready to present on week 10 for your group project. And then we'll just go back over all the content week 10 because we are actually finished with content on week 8. So then now we're down to week 9. Week 9 is unit exam 3. And then, of course, we meet after the exam every time to still go over content because you still have the HESI and you still have your NCLEX that you're looking forward to. So just, reviewing the information is what we'll be doing. And then in week 7 and 8, which is next week and the week after, we will be going over content for that last exam. We're going to be looking at financing the healthcare system. How is all these things paid for? We just go in sometimes and we don't really think it through. If we have insurance, we give that co-payment. But what is I don't have insurance? Can I go? Can I also see the doctor? If I don't have the insurance, how much does that cost? And then what about and we got some slides here in a few minutes we'll look at. So healthcare financing, all things healthcare financing. And there's so many moving parts to this. As you might have had different insurances over your lifetime, and then you couldn't do certain things. You may have lived in different states. This service was offered in this state, then you went to this state and it wasn't offered. That financing part is really complex. It's a huge piece. And then of course we'll look at some theorists, and then that should be all of our content. Again, doesn't seem like a lot of content, but that is just being able to apply it and think it through. And then that brings us to today, week 6, unit exam 2. All right, so let me share my screen. Let's go ahead and get started with our content here. So I do have a question for you. So they have called up on you to design the perfect healthcare system. The perfect healthcare system. They want your input. So in the chat, remember we use the chat, you all, just to make sure that you're responding when we say use the chat and everything, because that validates that you are participating. And so when we complete our professional development weekly, it says that you participated and things like that. Make sure that you're completing your quizzes and everything on time. You all, every point matters. Every point matters. Okay, so they've called up on us to design the perfect healthcare system. So we have 6 things listed here. Of course, these are not all the things that we need to think about, but select one of the 6, just one of them. And think about everything from A to Z as far as services needed, people, ages, where, and I don't want to limit your thinking, but if they're calling up on you to create the perfect policy for financing for their new healthcare system across the United States, what would that include? So take about 3 minutes and, drop 1 line or 2 lines telling us your strategy, your thoughts on what needs to be done to meet the needs of everybody, no matter the disease process, the pay status, no matter the location, for one of these. And then share it out so everyone can see it. I'm going to put my timer on for 3 minutes, and then we'll look at them here just a few minutes.
Doesn't matter which one we pick.
It doesn't matter. Select
Okay.
one. Does not matter. And the timer has started. So 3 minutes. So just kind of think it through and give us like a 2-sentence response. Well, we know if you were creating this perfectly, of course, you would have probably volumes and volumes, but just 2 sentences, like a good overview. 1 minute, 15 seconds left. So they've called upon you to create or design the perfect healthcare system. Select one of the six and just respond what policy, what thoughts, what things need to be thought about, included in that perfect healthcare system. Just 1 or 2 sentences and then share out to the group. Make sure you send it out to everyone. 50 seconds left and then we'll move forward. Right, let me stop sharing here and see what we have come up with. Let me just look at your responses. Okay, access, because a lot of people don't have access to healthcare because they have no insurance or can't afford it. So I will want everyone to have at least access to healthcare. So that's a thing that we're going to talk about. If you don't subscribe to these different insurances, and then the thing about it is, if you do subscribe, certain exams and procedures, you must get that referral. It must be approved. So does that limit a person from taking care of themselves and managing their disease process? It's rare that a person don't want to take care of themselves. It's usually assets, all the moving pieces to be able to get the resources, to get the understanding of the disease process, to be able to get the equipment and things like that. Finances, focus on preventative care. You're going to hear that a lot, preventative care, because we, as a nation, spent a lot of money on health insurance. People filed bankruptcy. This financing piece might not seem like a big thing, but if you had, the next time you go into the doctor's office, just ask the person, hey, how much would this visit cost if I didn't have insurance? And you can see the difference in that price. You like, oh my goodness. And so they said, we're paying all this money for healthcare. Even if you're insured, you may be underinsured, but some of these disease processes, can we just prevent them altogether? Let's put more money towards preventative care, make preventative care more accessible. Let's see, technology, due to the constant upgrades and phasing out, keeping everyone user friendly. So the other piece of that is, what about the people now that are 90 years old and 80 years old? How do they get accustomed and gain an understanding of that technology? So do we have classes for them? Do we have someone, a navigator that's at the doctor's offices, that's there to, walk with them one-on-one, to work with them one-on-one? So that technology, yes, that's what we're trending to. Think about those people that are not tech savvy. How can we still provide the same services and everything for them? The workforce, what type of task is in the workflow, organizing the staff and the roles of the staff. And so good responses. And that's where traditionally you sat in the classroom between whatever business hours, and that's how you matriculated through nursing school. But since the turn of the century, we have hybrid. You can do online, night classes, and all of that has helped with that workforce. But we're still short-staffed. There's still shortages. They've created other professions. So when the pandemic came about, they created what was called the medication assistant. I may be saying that wrong. All these other professions became available so that we can address the needs of the people. With technology, with advances in information, people are living longer. And so with that being said, who's there to take care of the people when they come into the doctor's office, when they come to the hospital? And so that's why you see the difference in all the different nursing programs and healthcare programs all together, because they're trying to offer different opportunities with the same worth and the same foundation so that people can get through. And so we have that workforce in order to take care of our the patients, the people that are needing the healthcare. So good responses. All right, so they got our input. Let's see, 3 more minutes. We'll go to our first break. So who pays for the healthcare? Who provides the healthcare? How do patients access that care? How is quality measured? That's going to be, they've come up with all these different things to try to make sure that we provide the best care we can for all of our patients. And so that people are reimbursed. And so quality, that's a new thing that they have in there. So remember, I said probably a couple of weeks ago, if you work in certain facilities, they have this quality of improvement team, and you may be asked to work on that team or that committee. And what you do is you'll go around and you administer surveys, whether or not it's electronic, verbal, or whatever. But they want to ask the patient, how was your stay? How was your stay here? How was your care? Did the nurses speak? Did you see them wash their hands? Then another piece of quality is they look at the number of readmissions for the same diagnosis. So then that's where insurance companies, they're looking at quality. Well, if you would have taken care of the patient, all these things the first time, maybe this client wouldn't have been readmitted within, 15, 28 days. And then how do we serve the underserved population? Anyone could be underserved at any moment in time. A storm comes through, we're without shelter. We're without power, running water. How do we still get the health care in the instance that there is disaster? So that perfect healthcare, they've been working on it, but so far we haven't quite got it all figured out. So we have PPOs, DRGs, MCOs. You'll hear about all these different systems that were created so that we can provide that best care for the clients. So Medicare, when we say Medicare, what age do you think of? What's the age of those people?
65 and older.
65 and older. Generally, that is who Medicare. I like to think of, we take care of our elderly. So that's how I've always remembered Medicare. We take care of our elderly. Generally, it is for 65 and older. There are some chronic disease processes where Medicare, that system has thought, well, hey, if a person has this disease process and they're not 65, they still might need these services or these resources that we offer. Because you think about a person that just has hypertension, they may have to do self blood pressure monitoring. They may be on some medications. They may have some lifestyle modifications. They may start walking, watching their salt in their diet, and they're able to manage that hypertension. But now let's think about someone that has COPD. Let's think about someone that requires dialysis. So, it's not a level playing field. So that's why Medicare, there is generally 65 and older, but there are some disease processes that people might have that can still qualify for Medicare, and they're younger than 65, but generally it's 65 and older. Okay. Oh, the DRGs, we have a slide on this. So Medicare changed from fee for service. So initially they were, okay, you come in, you get your blood drawn for a CBC. Okay. You had blood draw. You had labs done for a CBC. Okay, this cost $25. Okay, you came in, you had your right knee replaced. Okay, so you came in and had surgery, and it was this price. But what they transitioned to, because we're still trying to figure out this perfect healthcare system, they changed to these DRGs, diagnostic related groups. We'll look at the word diagnosis in here. So what Medicare bases their payment on now is the diagnosis. So if a person comes in and have right knee replacement, they have this set amount that they have done all the literature searches, they have the latest evidence, and they say, hey, it costs $50 to replace his right knee. Anything outside of that, that's fine, but we're only going to reimburse this facility $50 for replacing his right knee. And I'm just using some, fictional numbers or whatever. But essentially, the diagnostic is based on the diagnosis. So that's what Medicare has changed to. And we'll have another slide about this MCO managed care and PPOs and all of this. We'll have more information on this. So HMO, PPO, point of service, open access funds. Okay. So managed care aims to reduce excessive and unnecessary care. So think about the word manage. So as a nurse, you can be on that team that's working for that insurance company. And each time, what happens with that managed care, that facility that they're at, whether that is home health, long-term care, they send up a communication to the insurance company. They say, hey, we want to do this procedure. We want this patient to have therapy. We want this patient to have this medication. And so as that nurse, they look through the charts, they look at what's going on, and if they look at the documentation, the vital signs, all of these, whether or not the patient's complying with the medications or not, and they say, hey, okay, go ahead and get therapy with this person. Or they may say, no, therapy is denied. So that's how this managed care. It ain't, but the whole point of it is not that they don't want people to get the care, but they're looking at supposedly the documentation, the evidence, and they say, hey, no, we think this is unnecessary. So managed care aims to reduce or decrease excessive and unnecessary care. Because there are sometimes you may have experienced this before or heard someone say, hey, I went to my primary doctor, they drew blood, they did a CBC. When I went to my specialist, they drew the same lab work. I just had it done. So the people that came up with the managed care system says, hey, we need to reduce excessive and unnecessary care. Okay, so know that. Providers receive a lump sum per patient for a set of services. With managed care, like the example that I just gave about the diagnostic related groups, managed care, they get this lump sum. Right knee replacement, $50. Now, if the person has complications, what if something's wrong with the device they put inside the knee? Managed care says you got this lump sum, figure it out. So what happens is those healthcare facilities, they eat up that leftover cost. So the right knee replacement, managed care gave the facility $50, but what if that knee actually costs, and to take care of that patient actually costs $100? So who pays that $50? That healthcare facility or that patient? And so just think about the healthcare facility. After so long, they're not getting reimbursed for all these things. Hence, I know you've heard of hospitals and long-term care facilities going out of business because their expenditures, they're not getting reimbursed for the services that they're actually providing. And so eventually they can't stay open. So managed care aims to reduce excessive and unnecessary care. They get this lump sum for the services. This approach can motivate payers to control costs by restricting services. And so managed care people were like, oh, wow, this might be good because the facilities get this money up front. But then they thought about, hey, facilities know that this is all they're going to get. And it's an honor system. Is it going to be where this facility's healthcare providers are not going to perform tests and things because they know if it leads to something else, this is all we're going to get. This is the only reimbursement and money that we're going to get. So there were concerns about compromised quality and constraints on patient choice with this managed care. Okay, so are we clear on managed care? Managed care. All right. And so we're not going to take our 15-minute break. We're just going to keep pushing you out because even though I know we don't have any new content for this week, but I want to make sure that I'll just owe you, just tell me I owe you 5 minutes next week. Are we clear on managed care? So let me take this off my screen. Let me stop sharing. All right. So let me make sure I have any questions here. Okay. So Medicare, you said 65 and older, we're taking care of our elderly, but there are some disease processes that Medicare, if you are under 65, that you still can qualify. They call it dual. And we'll talk about it. There's a slide on that. And then there's managed care. What's your understanding of managed care? So be going through your mind. I gave a lot of information on managed care. So what's your two line? Managed care, the whole point was to manage that care, but to reduce unnecessary, expenditures and procedures being done. But as a result of that, there were concerns about the quality of care, and so eventually they came being done. And you may have even heard people say, well, I don't know why my doctor just wouldn't order this next test. They told me if I, did this test, it would, it would help, or they would find out what they needed to find out to move forward. So more than likely that insurance company they subscribed to was a managed care insurance company. This financing part, you out, it doesn't seem like a lot, but it's complicated. All right, so the American healthcare system change results, minimize client length of stay utilization. And you all are probably too young for this, but ask some of your older relatives and ask how long did people stay in the hospital when they gave birth and compared to what they do now. So, as a result of all these different changes to healthcare, they started, mandating, hey, there's no need for this person to be in the hospital as long. What is warranting them staying here? What are we doing? So then therefore you hear the shorter stays now. But then you get dinged if you discharge them too early because the patient really hadn't healed enough and they get those readmissions. All right, so let me read through this right here. The Affordable Care Act. This is where you may have lived in one state and lived in another, or have heard relatives say, hey, when I lived here, I was able to get these services, but when I moved to this state, I was not able to get these services. So the Affordable Care Act, initially intended to mandate Medicaid expansion. So Medicaid expansion, so states usually have to come up with these monies. But when the Affordable Care Act came about, the federal government was going to donate or give money to the states in order for all states to be able to provide whatever services that were needed by the people that live in those states. But because of the Supreme Court ruling, it said that, hey, if states don't want this money, then we can't make them take it. But as a result of that, when you live in certain states, some certain resources are not available because the states can't afford it. And then a second thing, the states did not take the money from the federal government to be able to provide that service. So as a result, Medicaid expansion became optional for states. This decision has led to variations in Medicaid coverage across the country. While some states expanded eligibility, hence you can go in some states and you can receive all these different resources, go to other states, it is not available because healthcare is expensive. For the most part, states can't afford all these different resources without some help or some donation. Where do those donations come from? It would have come from the federal government, but states, so the governors decided and those healthcare teams decided, we didn't want the money. So Medicaid was not expanded in certain states. All right, so the Affordable Care Act, it allowed pre-existing conditions are covered. Prior to the Affordable Care Act, if, for example, we'll just say hypertension. So if you subscribe to an insurance company prior to the Affordable Care Act and you had hypertension already listed on your record, that insurance company, everything that was done to help you manage your hypertension, whatever the disease process was, that pre-existing condition was not covered. It's like, wow, what in the world? How do people pay for their insurance, their health care? Yes, because people have, these mounting of bills now because prior to the Affordable Care Act, if you had a pre-existing condition, your insurance company was not required to assist you with that because it was listed as a pre-existing condition. All right. So it eliminated lifetime covered limits. So what happened prior to the Affordable Care Act, say, for example, if you had hypertension, there was this rule that said that, for a lifetime, that insurance company, if it was not a pre-existing condition, so it was new, once you got your insurance, they found out that you had hypertension. That insurance company only allowed, we'll say $5,000 for that doctor's office, for visits, for any type of care that was related to hypertension. So mind you, for example, that person could have been 35 years old and all the tests and all the medications, everything related to hypertension may have been used up, when they turn 40. This person is still living. They're 60, they're 80. Beyond that, that person has to absorb that cost. But because the Affordable Care Act was enacted, it eliminated that lifetime coverage. Because think about it, people are living longer because we're able to manage care. Why should a person be penalized because it took more labs or more tests or more procedures? It took more medical equipment for me to manage my disease process. So people were like penalized. So the Affordable Care Act took away that lifetime coverage limit. And then also it eliminated that pre-existing condition penalty. So included mandates for employer purchases of insurance, because insurance is expensive. You have to outright pay for it yourself. So it encouraged employers to at least offer it. People didn't have to subscribe to it. The goal was to increase access to healthcare coverage, because rarely it is a person that don't want to take care of themselves. It's that they can't pay the fee to subscribe to the insurance. And if you can pay the fee to subscribe to the insurance, we're going to have another slide here in a few minutes. You have a copay, you got a premium, you have these yearly fees that you have to pay before insurance will actually cover their part. So the goal was to just increase access, and then for the person to be able to pick the plan that they wanted that was better for them. So fee for service, you all, it is what it is. Whatever the service is, there's a specific fee. Capitation set monthly fee charged by the provider for each member of the insurance group. And you kind of saw this with those private pay insurances like the Blue Cross Blue Shield. And Blue Cross Blue Shield was pretty much in every state. So private group health insurances, whose individual contributions for a common group goal offered by most employers in the United States. Private individual, these are non-group health insurances offered by insurance companies, and that person can actually purchase that insurance individually. And these are all these different parts. So in order for a person to have insurance, more than likely they're gonna have to pay a premium. They're gonna have to subscribe every month. It's like for the cable company. In order for you to subscribe to continue to get your power to stay on and your water to still run, you have to pay this premium every month. Then there's this deductible, this yearly amount that we must pay out of pocket, the patient, before the insurance companies will decide to pay their part. Then you have this copay, the amount of the insured person must pay at the time of the office visit. And then you have this co-insurance. Once the deductible is met, the percentage of the total bill the insured person must pay, the insurance company pays the remainder. So again, going back to that original question, that slide, like creating that perfect healthcare system. Just think about all this. Should we eliminate all those things? Is there a system where we can eliminate that? Because think about it, we still have to pay the people, the nurses that's going to be working, all the healthcare team. We have to keep those hospitals, those urgent care.
Can you go back to that slide?
Mm-hmm. They still have to keep the lights on. So we don't want to cause undue distress to the patient. You're welcome. But we also want to think about the facilities, because remember, they have to pay their light bill as well. They have to pay the water bill also. So what is that perfect system? Is there a perfect system? So the next couple of slides talks about Medicare and Medicaid. So when we talk about Medicaid, what group of individuals would qualify for Medicaid? We said Medicare is 65 and older. There are some chronic conditions that will qualify, but Medicaid generally is what? What's the focus to qualify for Medicaid?
I was pregnant and children.
Pregnant people.
And
say that again. I kind of heard two people.
I think it's pregnant women and children. And
but what qualifies them?
Low income.
Income. Exactly.
Yeah,
that's the key thing for Medicaid is income. Yes, you still get all your services. You get all your services, but it is income. So Medicare is the age 65 and older, where there are some exceptions of where that you can be under 65 and still get Medicare, but there are certain disease processes. And then Medicaid is specifically income-based. All right, so we need to know Medicare does not cover long-term custodial care. Medicare does not cover this. Medicare is solely funded by the federal government. It covers people age 65 and older, regardless of income. So once you turn that magic number, you can subscribe to Medicare, and it's not income-based. Okay. So then Medicare, we have this on another slide. It has, okay. Medicare, we have A, B, C, and D. A is in the hospital. Okay. B is outpatient, so out of the hospital. So like the doctor's visits, outpatient care. Then D is for drugs or medication. I think we're hearing someone talk. You out. Make sure you're on mute unless you're talking to us. We don't want to record anything. And then C, Medicare Advantage plan offered by private insurance companies that contract to Medicare, offers prescription drug coverage as well. So with the Medicare, you get A, B, and D. But a person can come in and say, hey, I want to also pay for and subscribe to Part C. So A is in the hospital, inpatient. B is outpatient, doctor's visits, anything that's not related to being in the hospital. And then D is medication. And then we have Medicare Part C. A person can subscribe. We go back and make sure we got everything. So Medicare does not cover custodial care. Does not cover custodial care. All right. I have that on there twice. Okay, so that's it for Medicare.
What would that be consisted of?
So someone that does not require skill.
Oh,
To
okay.
think about all your skills that we have learned to do.
Okay.
There, so someone that's like just requiring assistance with their ADLs. And they get it initially, but it says long term. Okay. So Medigap, it is what it says. It stands in a gap. So those services that are not covered, someone can subscribe to an insurance company that's listed as a Medigap company. And so what that does is they still have to pay like copay and all that stuff, but those services that are not covered, it stands in the gap. Again, is there a perfect system? We're trying to get there, you all. We said Medicaid is income based. It's income based. Remember, it's jointly funded by the state and federal governments. But remember, Medicaid expansion, if your state decided not to expand, then that's why you can go to certain states and certain services are not offered. So Medicaid, you still get all your services and everything, but it's just how those services are being paid for. Okay. All right. So if a patient meets the income and asset requirements, they may be eligible for both Medicare and Medicaid, dual eligibility. So there are some disease processes out there. The person, because of their income, because they're too young, because they're younger than 65, they may automatically qualify for Medicaid based on their income. But then because of that disease process, I know chronic kidney disease is one of them. And there are several others. So they may qualify for both. So you do have people that will have both Medicare and Medicaid. Okay, this could provide additional coverage and financial assistance for their healthcare needs. Because now you're seeing a big thing now where long-term care, you can subscribe to an insurance company because people are living longer. And, people are deciding to leave their homes and go live in long-term care facilities. So they have an insurance plan that assists with paying that. But outright, before a year or two ago, there wasn't a plan that covered that. You either fell up under that Medicare or that Medicaid visit to get those skills provided for you in the long-term care facilities. All right, so here we have CHIP. CHIP specifically targets children in families with incomes that are too high for Medicaid, because we just said Medicaid was income-based. So if I make $1 over whatever that amount is, I don't qualify for Medicaid. But then on the other hand, the private coverage is too much. I can't afford it. So what happens? So they've created this CHIP, Children's Health Insurance Program. And it's for children where families, my phone is listening to us. So this is where families, the children in families, if the income is too high for Medicaid, but then they can't afford the private coverage, CHIP steps in. So the children are still covered and can still get, their preventative services. They can get those well child visits and everything, immunizations and everything. But it's just saying this is who's going to pay for the healthcare. Excuse me, CHIP. And I think CHIP was born out of Blue Cross and Blue Shield. They kind of created this thing they got with the Medicaid, Medicare, and all those people. They got together and said, well, hey, we want to at least try to take care of the children. And so, because they can't fend for themselves, so they created this CHIP program. Doesn't mean that they don't get the same services and the best care that no one else gets. It just means that this is who pays for those services. All right, so we'll get into more of this on next week. We haven't taken our last break, and it is time. So I will stop right here because remember, this week we didn't really. Only thing was down for this week was the exam. So we're getting ahead of, but you see where we're going. This finance and this healthcare is complex. So make sure that you are looking at your required readings. Make sure that you're working your way through your quizzes. That's a one-time thing. So make sure that you have enough time to sit and take that quiz and do your best. We have our group project that's coming up. We meet 2 times and then we have unit exam 3. All right. Take care and we'll see you next week.
Professor Ford.